Our next speaker is Dr. Brian Rodrigues. Brian will be speaking about cardiovascular disease and diabetes. Brian is a professor in the Faculty of Pharmaceutical Sciences at the University of British Columbia. Dr. Rodrigues came to Canada in 1983, obtained a master's and PhD degree in pharmacology at the University of British Columbia, and then did postdoctoral training at the University of Calgary. Throughout his career, Dr. Rodrigues has pursued his interest in diabetes and heart disease. His work has been supported by all of the major health research funding agencies in Canada, and his findings have been widely published. Brian takes a strong interest in training and mentoring the next generation of researchers. In the past 5 years, 11 PhD students have graduated from his lab, and they are currently completing postdoctoral fellowships at Harvard, Yale, NIH, and the University of Toronto. At present, his lab has 6 PhD students, and I'm sure that in the context of describing his work, Brian will also talk about his students. So please welcome Brian. And if you want to note your questions while Brian is speaking, green cards for Brian. Pink for Lorraine, green for Brian. Thanks, Brian.
Thanks, Jan. So the first question always, where the hell did you get a name like Brian Rodrigues? So just to basically tell you, my background. My parents come from a small place called Goa. It's right here near the coast of, very close to Bombay. And Goa was a Catholic, it was Portuguese, so they converted everybody to being Catholic. And so Brian is my Christian name, and Rodrigues is probably from some wayward Portuguese sailors. And then the other thing I wanted to introduce is that, I thought this was a great slide. It was by Watson, the guy who actually discovered DNA. And he actually got the Nobel Prize. And he wrote a book called Avoid Boring People. And it's, this concept that scientists are really boring. So actually, he should have written a book, How to Avoid Becoming Boring. And that's what I do. To avoid becoming boring, I actually do have a life. And so I tell people that I do science and I actually fish. And so that's on the Harrison River, and that's, yeah. So if you look at that, most people say that that's much bigger than this thing out here. But anyway, it's I live in Vancouver, and so you can do this, and so it's fantastic. So, and then just because I fish, I actually fish all over the world, and we fish the Caribbean, and so we started in Key West. We went to Cozumel, went to the Grand Cayman, practiced my Don't Ask Me Man in Jamaica. Went to Antigua, Dominica, St. Kitts, St. Lucia, and we were just in the ABC Islands in November. So as you can see, I live a very fulfilled life. So now on a more kind of serious note, right? So you must have seen this quite often, that you'll see the worldwide epidemic. You can see in 2000, as you go greater in blue, these are the number of people who are going to be diabetic. And you can see that by the year 2030, there's going to be a significant number of people who are going to be diabetic. Now, just because of numbers, sometimes the colors don't make any sense, but if you talk about the numbers, 90 million people in China, 61 million people in India, and in USA, 24 million. So there's a significant tsunami that's basically happening. And you'll see this in the popular press, right? Diabetes, a growing health risk, and as you can see out here, the diabetes epidemic. So it's actually in the popular press now that this condition is global and it's a big problem. Now, when I talk about Canada, it's about 10 million individuals that suffer from diabetes. we spend a lot of money treating this condition, almost $6.3 billion, and it's going to be $16.9 billion by the year 2020. So we spend a significant amount of our healthcare dollars in treating this condition. And in fact, actually, it's a really growing problem. Like, as you can see, but there are younger and younger people who are type 2 diabetics, actually. And it doesn't take a rocket scientist to figure out why. That, with the incidence of obesity, you actually have increasing numbers of people who are young, who are basically type 2 diabetics. So it's a big problem. Now, I have to give you some context about the research that I do. So, when we talk about diabetes, we talk about type 1 and type 2 diabetes. That's the major players. But as Lorraine said, you'll also have secondary diabetes, that is secondary to pregnancy and cancer and gestational diabetes, right? So at least for the purposes of this talk, I'll mostly concentrate on type 1 and type 2 diabetes. So, everybody shows a heart, and I have to show what a pancreas looks like. So this is the organ that actually makes insulin. It's kind of this oblong kind of, organ, and right here, if you can see out here, it's these islets of Langerhans. These are the kind of the critical cells that actually make insulin. And basically what happens is that if you look at the islets, if you can see that, these are the beta cells. These are the actual cells that make insulin. Now, basically what happens is that during type 1 diabetes, these cells are basically killed. There's a lot of research going on why do we actually lose our beta cells, but really your insulin goes down to almost zero. So really when I talk about type 1 diabetes, really nobody knows, well, there's a lot of research going on in terms of trying to find out what's this event that actually causes the beta cell destruction. But basically, as you can see out here, there is a genetic predisposition, but that over time, as you can see out here, you basically lose your beta cells. So you're basically, all of your beta cells are dying, so you don't have any insulin. Now, when you do have that, basically, you become type 1 diabetic. So in other words, you don't have those cells that are actually making insulin. Now, what happens when you have that? These are Banting's first patients that, most of the people up to that time basically died. And so it was a great discovery by Banting and Best, McLeod, and Collip at the University of Toronto, who showed that diabetes was because of a lack of insulin, and that if you give your insulin back to these patients, you can actually have a dramatic recovery. Now, when I talk about type 2 diabetes, it's a little bit different. It's a hazardous waste, as you can see out here. So you become obese, unfortunately, and when you do that, when you actually become obese, you become insulin resistant. So now this is a kind of a cool term, because you actually have insulin, but the insulin just doesn't work. And because of that, as you can see out here, so just because of this obesity, as you can see out here, you basically start to put on fat in all places that you shouldn't really have fat. So as you can see out here, this intra-abdominal fat is the one that is really, really bad, because what happens is that if you actually develop this intra-abdominal fat, you become insulin resistant. Your insulin simply doesn't work, and you become type 2 diabetic. Now, people sometimes don't understand what is the meaning of insulin resistance. And I have this cool slide to show you that insulin is like, as you can see out here, the key. And so every time you have the insulin, it goes into the lock and opens the door. All of the glucose that's present on the outside now goes into the cell. So now imagine a key that doesn't work. It needs WD-40. So now you can see, and that's what metformin is really. Metformin is really WD-40. So you have this key. It can't fit into the lock. It can't open the door. The glucose cannot go inside. The glucose stays outside, and you have hyperglycemia. So when you have people who are insulin resistant, obesity causes insulin resistance. Obesity prevents this insulin from working, so that you have now hyperglycemia. Now, just to show it to you in another way, people always talk about obesity and exercise. Now, so this is a kind of a cool slide to show you that look at this insulin resistance. As you become obese, and if you just follow me this, it's a kind of a really easy slide to understand if you follow my point here. So here's your insulin resistance, because as you become obese, as you gain all of that intra-abdominal fat, you become insulin resistant. As you become insulin resistant, right, your body starts to make more insulin, and as long as your body is making more insulin, your glucose levels are normal. However, after some time, your insulin basically, or your pancreas, as you can see out here, simply cannot work enough. It's like beating a dead horse. And under this condition, as your pancreas starts to fail, as you can see out here, now the insulin starts to drop. The insulin now cannot keep the glucose in control, and your glucose levels start to rise. So it's a pretty cool slide to show you that, when you can, when that's why the number one treatment for type 2 diabetes is diet and exercise, because if you can do that, you can prevent insulin resistance, you can simply save your pancreas, and you can prevent this hyperglycemia from occurring. So basically, when we talk about type 2 diabetes, we always talk about type 2 diabetes being here's your Titanic, and here's the hidden danger. So there could be many people in this room, or myself, who could be insulin resistant, and we wouldn't know about it, right? So you could be insulin resistant, and your insulin may not be working. It's only when your pancreas fails that you now start to see type 2 diabetes. So the question then is that why do you become obese, right? So it doesn't take a rocket scientist to figure that, it depends on how much you eat or how much you expend, right? So it's energy intake versus energy expenditure. So, so this is a pretty interesting slide, because it shows you that it took us 2.5 million years to become this, and it only took us 50 years to become this. Just to give you a sense of, how we've evolved, really. And again, it's just the obvious now that, this idea that, we spend maybe 4 to 5 hours, watching television and all of the things related to the fast foods. And, this whole thing about, our obsession with food, just the volume of food that we eat, right? So that's just the amount of energy that you're getting in. So, it can go anywhere. It just then goes and it gets stored in fat tissues. So that's number one. It's not only the amount of food that we eat, it's also the type of food we eat. So for people at the back, this is weapons of mass expansion. And it's Jack in the Box, McDonald's, Taco Bells, etc. So it's not only the amount, but also the type of food that you eat. And then, of course, it's also the quality. Can you believe this was not very long ago, 1950s advertisement? It says, for a better start in life, start cola earlier. And it says here, for people who are at the back, it has been proven that babies who start drinking soda have a higher chance of fitting in. Do your child a favor, start them on a strict regimen of soda and other sugary carbonated drinks. And so if there's anything that you can do, you should just avoid that, right? So that's one thing. So that's just about the food. Of course, the other thing is the exercise, right? How many times have you seen this? I always call it the stairs versus the escalator. That, when we shop, we just, shop 5 blocks away from where we should be, and we walk all over the place. And there was this terrific slide at the last ADA meeting, where they talk about sitting is the new smoking. And so this idea that exercise can play a big role in obesity is something to be concerned about. And I think this slide actually makes my point that if you look at they were following people in this British village, people who had type 1, so very few people, 10% of the population. But look at type 2 diabetes. So they were following these people, and you can see the incidence of type 2. And all of a sudden, there was a big drop in the incidence of diabetes. And look at the year, from 1940 to 1946. There was a big drop in the incidence of type 2 diabetes. And it does, again, the obvious thing was it was World War II, and people were rationing, and people were walking all over the place. So just to make my point here that type 2 diabetes is controllable, and you can start with diet and exercise. Now, having said that, it's not only about all diet and all exercise. There is a genetic component. And if you look at type 2, there's a genetic component in type 1 also, but the genetic component is higher in type 2. And just to show you that in the Pima Indians, for example, and it could be our native population also, you can see that in the Pima Indians, about 60% of that population is type 2. So type 2 diabetes has a very high genetic component. So now, the question is that, so what? Why are you interested in type 1 and type 2 diabetes? Because of this reason. For type 1, as you can imagine, with the DCCT trial, you got to do this 4 to 5 times a day or more. You got to take your blood, you got to put it on a glucometer, and then based on that, you got to give yourself an insulin injection. Unfortunately, you still can't give insulin orally, so you have to give it by injection. And you got to do this 4 to 5 times a day, right? So that's number one. And for type 2, it's the same problem. It's about compliance. That you tell people that you need to diet and exercise, and you basically have to stop pop, and you got to reduce the amount of food that you eat. And again, it's a problem with compliance. So both with type 1 and with type 2, you have problems with compliance. And because of that, because of problems with compliance in both type 1 and type 2, we have the complications associated with diabetes. So that's my research. Basically, we're studying, out of the many different complications that occur with both type 1 and type 2 diabetes. As you can see out here, you have the retinopathy or the eye problems. You have kidney failure. You have the peripheral neuropathy, so you lose sensation in your fingers and toes. You have stroke, but really my research is all about heart disease and hypertension. So the majority of people, eventually when they succumb to this condition, is because of heart disease and diabetes. So all of my research is basically studying why does the heart basically fail during both type 1 and type 2 diabetes. Now, the question is then, so what type of research do you do? So generally, when I talk about my research, is these blood vessels called the coronary blood vessels. So what happens with these blood vessels is they get blocked during diabetes. There's a very high chance that your blood vessels will get blocked. So this is a normal coronary blood vessel, as you can see out here, and this is the process of the coronary blood vessel getting blocked. So what happens is when this coronary blood vessel gets blocked, really what happens is that this is a nice coronary blood vessel. Can you see nice, beautiful, nice open coronary blood vessel? And you can see this blockage starting to occur, as you can see. And now as you go further, you can see further blockage. And then what happens, as you can see out here, is that there's so much of lipids that are basically getting accumulated out here that eventually it closes the blood vessel. The blood vessel ruptures. And as you can see out here, this surface area is now decreased. Now the blood can't flow because it's all blocked and your heart fails. So really one of my research projects is studying why do these blood vessels actually get blocked? And once they get blocked, how do they actually cause heart disease? Now, so that's the first one. So that's what I'm showing you out here. See, that's the blood vessel. Here the blood vessel is blocked. And the moment this blood vessel is blocked, all of the tissue that's downstream of that blocked blood vessel, all of it dies. And that's what you call a myocardial infarct. So what happens is that when this dies, obviously, you only have one heart and you cannot regenerate it. So unfortunately, you have heart failure. Now, so that's one way of doing it. The other way of doing it is the other projects that I work on is, whenever this heart contracts, you need fuel. It's beating at 72 beats a minute. So it's basically requiring fuel, as you can see actually. So the other project that I'm working on is studying what is basically the driver of this fuel to the heart. And I was trying to struggle to see how to explain this. And the only way I could explain it is by this one. And so basically, when I talk about fuel, in people who are diabetic, they can't use glucose. So as you can see out here, the glucose becomes empty. You cannot use glucose as a fuel. So unfortunately, when you cannot use glucose as a fuel, the heart starts to switch to fatty acids, or they start to switch to fat. So it's almost like going from a regular fuel to a high-octane fuel. But the problem is that this high-octane eventually becomes basically, as you can see out here, rocket fuel. So when the heart cannot utilize glucose, and it starts to use alternate sources of energy, this alternate sources of energy is basically what kills the heart. It's almost like, you're putting rocket fuel into an old Beetle. It just doesn't work. And I think this is the other mechanisms that we are working on. That is, when the fuel change happens, how does the fuel change from glucose to using this very high rocket fuel? How does it actually damage the heart? And so that's my other, the other projects that I work on. And so then if you just I just want to summarize that if you look at the heart disease or the cardiovascular death rates, you can see that here's your normal patients and here's your diabetic patients. You can see that just without any risk factors, if you have diabetes, you have an increased incidence of heart disease. And as you can see out here, if you smoke and you have hypertension, if you smoke and you have hypertension and you have high lipids, then you have a higher chance of developing cardiovascular disease. So, my research has focused on mechanisms as to why and to how do you prevent this heart disease that's taking place in people with diabetes. And, Lorraine said, I do want to, this is the first time I'm actually publicly doing this, that I'm actually a poster child for somebody who was funded from CDA for their entire career. So, and it's a marriage made in heaven. So I got my first scholarship award in 1993. So I'm older than I look. I got a scholar award in 1993. In 1997, all of my students started to get funded. So, the CDA doesn't only fund research, we are so proud of our training program. So my salary was literally paid by CDA. So, sometimes people think about research and they think about all of the cool stuff that we do, but we also need a salary. And living in Vancouver, as you can imagine, is pretty difficult, right? So in 1997, my students got funded. In 1998, I got my first grant, and Matella will tell you how strenuous that process is. In 2014, my grants were renewed from CDA and CRHR and Heart and Stroke, so it was a great year. And in 2015, as you can see out here, there's all of these students, so not only was I trained by CDA, all of my students have been funded by CDA. And these students now, 4 of them, out of my first batch of 4 students, Thomas is in Dalhousie as an assistant professor. Sanjay Ghosh is at UBC Okanagan as an assistant professor. Dek Chi is in Memorial University as an assistant professor. And Minsuk is in South Korea and Eva Women's University. So, this point that it's a continuous process. Funding it's not instant gratification. You won't see something like, show me what you have done for me recently. No, it's not going to happen that way. It takes a long time, from 1993 right up to 2015. Just want to say that, diabetes research in Canada and across the world is in good hands. So I want to just make sure that, people get that. And then, having said that, I just want to put one plug here that, we talked about money and raising money. And this is my last slide, by the way, just to show you the public funding. And look at the G8 average. That's the G8 average, and look at where we are. It's basically not only are we kind of low, it's actually dropping. And so, this idea that, I know we have always had problems and the stuff that we do, we actually require funding. And so under these circumstances, I'm hoping that, the Canadian Diabetes Association, with all of your help, can actually make this number, as you can see out here, even higher. So on that note, thank you so much.